Okay, let's unpack this. Thanks for sharing these university session notes. They really are quite something.
Yeah, definitely.
We're diving deep into how nurses are learning to tackle, well, a really persistent challenge in healthcare, harmful alcohol use.
Hmm.
And this isn't just, abstract theory. These notes give us a fascinating look inside how future healthcare professionals are actually trained, how they grapple with the tricky human side of behavior change.
Exactly.
So our mission here in this deep dive is to pull out the most valuable insights, the practical strategies from this session, sort of a shortcut for you to grasp key ideas like stages of change, communication tools, all in that healthcare context.
And it's so vital, this topic. Harmful alcohol use is, it's a massive global health issue.
Yeah.
Understanding how frontline workers approach it, that's incredibly valuable for everyone. It was interesting, wasn't it, how a student in the notes pointed out its prevalence, specifically in Scotland.
Yeah, that really brings it home. Global problems, local impact. So, stepping into the session itself, the notes say it was longer than usual, about an hour and a half.
Yeah, the professor added extra time.
And not just for teaching, right, but for reflection.
Exactly. The idea was for the students to really process it, think about their own role, not just absorb information.
And they really stressed the pre-reading, apparently. Made the session a lot easier if you came prepared.
Which makes sense. It lets you dive deeper in the session itself.
The structure sounds really hands-on, too. Very practical.
Oh, definitely.
It went through phases. Small groups on case studies first, then a whole group chat, then back to small groups, this time creating guidance, sharing that, then individual reflection, and finally whole group reflection again. It's not your typical lecture, is it?
Not at all. And that structure, it's deliberate. It forces engagement.
Right.
You're not passive. You're actively working with peers, applying ideas immediately to these cases, and then, crucially, that personal reflection bit. How does this affect me? How will I use this?
It helps make it stick, I guess. Turn learning into actual practice.
That's the goal. It solidifies it.
Okay, so let's get into the meat of it, those case studies. The notes give us two quite different situations. First up, case study A. Athiva. She's 21, a student.
Yeah.
Her situation, well, it sounds like a pretty classic story, unfortunately. Started drinking socially, fitting in. That was 3 years ago.
Right.
But now it's daily, and she's drinking alone.
Key signs there.
Yeah, and the consequences are clear. Grades dropping, she's distracted, pulling away from friends, even these anger outbursts. Her parents are worried.
Understandably.
They asked a nurse to step in, but when the nurse brings it up gently, Athiva's response is just denial, flat out. I don't have a problem. I'm fine. Drinking alcohol won't cause harm. All students do it. Helps me feel happy and relax. And about her parents. They're just being over the top.
Okay. So, based on that discussion in the session notes, what really jumps out is saying this is more than just, like, normal student drinking.
Well, the nights highlighted the daily drinking.
Crucial. And drinking alone.
Yeah. And then the impact, right? Academics, social life, her mood, the anger.
Those are the red flags they were training the nurses to spot. Definitely.
And her reason for drinking, the why, that's shifted too, hasn't it?
Seems like it.
Started as social, fitting in, but now it's internal, to feel happy, to relax. It's become a coping mechanism.
Precisely. Which, as the notes explain, puts her right in the pre-contemplation stage of change.
Because she doesn't see a problem at all.
Exactly. She's deflecting responsibility.
Wow.
All students do it. She's justifying, it helps me feel happy. Dismissing concerns, parents are over the top. No personal ownership of the downsides.
Yeah.
And this stage, the notes really emphasize this, it's often the hardest one to deal with.
Yeah.
You're not going to wave a magic wand in one conversation.
Right.
The key takeaway here is the goal isn't to, force her to admit she has a problem right there and then.
So what is the goal?
It's simply to sow a seed, gently introduce doubt, encourage maybe just a tiny crack in that denial without pushing her away completely.
Okay, so a seed, that makes sense. So facing that kind of resistance, what strategies did the nurses actually brainstorm for someone like Athiva?
Well, some interesting ideas came up. Things that might seem a bit counterintuitive if you just want to fix it.
Like what?
Like offering leaflets. But this is important, asking permission first.
Respecting autonomy.
Exactly. Offering info, not forcing it. They talked about educating her on alcohol's effects, but framing it as empowerment, giving her knowledge. Absolutely not a lecture.
The professor really hammered that point home, didn't they? Lecturing doesn't work here.
Guaranteed failure in pre-contemplation. And maybe the most subtle thing, just creating that safe space, planting that tiny seed so she might eventually think, maybe.
It's a real shift from the old expert tells patient model.
Completely different mindset.
Okay, now let's contrast Athiva with case study B Dave. He's 35, a taxi driver.
Right, a different profile.
And his situation sounds much more, well, established. He's been dependent for 10 years, uses alcohol mainly to cope with health and money worries.
Coping again.
His drinking's up to around 9 units daily. And critically, sometimes in the morning.
Morning drinking, that's a big one.
Yeah, leads to him calling in sick, neglecting things at home, causing arguments with his wife. But the huge difference from Athiva, Dave knows it's a problem.
He has insight.
Yeah, he tells the nurse straight up, I know I should do something about my drinking. It's affecting everything, my relationships, my work, my health. He even mentions spending savings.
So he sees the consequences clearly.
He does, but then he follows it immediately with, the thing is drinking really helps me cope. He calls it a vicious circle.
Okay, so the signs here are more chronic, more severe, it sounds like.
Definitely.
At the decade of dependence, the morning drinking sign of physical dependence, likely. And unlike Athiva, he's clearly aware of the negative impact across his life.
And the why is coping again, escaping worries.
Which puts Dave, according to the model, in the contemplation stage.
Right.
He's aware.
Well.
He sees the problem and the impact. He's thinking about change, but he's also stuck, ambivalent. He sees the bad, but also feels the alcohol helps him cope.
Oh, he's torn.
Exactly. And because he has that awareness, the notes suggest he might be much more ready to actually talk about change compared to Athiva, who's not even there yet.
And this is where the notes brought in a really key tool set for this stage, ORs.
Yes, ORs. Fundamental.
It's presented as like the core communication skills from motivational interviewing, MI. And the idea behind MI, the note said, is helping someone explore and resolve their own mixed feelings about change, drawing the motivation out of them.
That's it exactly. And OR gives you the how-to for that conversation. Let's break it down using the examples from the notes.
Okay.
OR is for open-ended questions. You're not asking yes/no stuff. You ask things that make them think, share more. Like, what are your thoughts on how drinking affects your daily life?
Opens the door.
A is for affirmations. This isn't just flattery. It's genuinely noticing strengths or efforts, even just their willingness to talk. Like, it's commendable that you're thinking about making changes. Build them up, builds connection.
Right.
R is for reflections. This is huge for active listening. You mirror back what you're hearing, show you get it. Helps them hear their own thoughts too. For Dave, maybe it sounds like you're feeling conflicted. You know it's causing problems, but you also feel it helps you cope.
Shows you're actually listening.
Totally. And S is for summaries. Pulling things together now and then shows you've tracked the conversation, helps organize it, lets them correct you if you've missed something. So we've talked about your concerns, the impact on work and family, and that part of you wants to change. Is that about right?
OARS. Open questions, affirmations, reflections, summaries.
Exactly. And the whole philosophy behind it, which the professor really stressed, is that the patient is the expert on their own life.
Not the nurse.
Right. Your job isn't to tell Dave why he drinks or what he should do. It's using ORs to help him explore his reasons and, crucially, help him figure out what the benefits of changing would be for him.
The answer has to come from them.
From their own values, their own mouth. It's about listening, understanding, caring, fundamentally.
That really changes the whole interaction, doesn't it? It's not about you having the answers for them.
It's about helping them find their own answers.
The notes also mentioned other ideas for Dave, like taking a holistic view.
Yeah.
Considering the money, the relationship issues.
It's all connected, right? The drinking isn't happening in a vacuum.
And again, that point about asking permission before suggesting helplines or resources.
Yeah.
Respecting his choice.
Crucial for building trust.
It's interesting, too, that the notes mention it was hard getting volunteers for the role play using these ORR skills.
Yeah.
Highlights how maybe challenging it feels to actually do this non-directive approach compared to just, giving advice.
It takes practice. It feels different. Less in control, maybe, but ultimately more effective.
So they've understood the stages. They've got the communication tools like ORs. The session then moved into creating practical guidance for day-to-day work.
Yes, part 3 and 4. What useful tips emerged there?
Okay, so the professor gave some basics for creating good guidance, said it should be based on research like the cases and MI.
Evidence-based.
Yeah. Keep it simple, easy to follow, use visuals if possible, and they mentioned the 7 C's of communication.
Yes, the 7 C's. Always good to remember, making sure your communication is clear, concise, concrete, correct, coherent, complete, and courteous.
Sounds like solid advice for any communication, really.
Pretty much.
And what about the student ideas for guidance? What came through strongly there?
Well, pulling their ideas together, one thing came up again and again.
All right.
The absolute need for a non-judgmental approach.
That seems key.
Totally. Someone suggested a flowchart idea, linking the stage of change to using ours, setting objectives, maybe SMART goals, but only if appropriate for that stage.
Tailoring it.
Yes, tailoring any education or advice. And explicitly avoiding that blaming language, like, stop drinking, you've been silly.
Cringe. Yeah.
Instead, focus on empathy. Acknowledging why they might be struggling, why they might rely on alcohol.
It ties back to that MI principle again, doesn't it? The patient is the expert.
Exactly. The guidance reinforced that. The nurse facilitates, helps the patient figure out their why for drinking, and crucially, what the benefits of changing would be specifically for them.
The students also had ideas about making change feel less overwhelming.
Like setting small, realistic goals. For someone like Dave on 9 units, maybe not stop completely tomorrow.
Right. Too big a jump.
Maybe just, could you aim for 7 or 8 units this week? Gradual change.
And then using check-ins not to police them, but to help them notice positive changes themselves.
Yes. Help them see, oh, actually, I slept a bit better, or I had more energy, or I felt less anxious. Focusing on those small, self-observed wins makes it feel achievable, reinforces their motivation.
That makes sense. The professor also made a point about education and fear, right?
Yeah, a really important one. Just dumping tons of info doesn't work. It's overwhelming.
People just switch off.
Exactly. And using fear tactics, look at this diseased liver, you'll end up like this. That often backfires.
How so?
It can just paralyze people. It doesn't necessarily motivate long-term change, which led to that powerful anecdote she shared.
Oh, yeah, from her psychology work, with men reducing drinking.
That's the one. They found the biggest motivator wasn't some abstract health goal. It was personal benefits that really mattered to them.
And the example was amazing.
Wasn't it? The man whose main reason, his driving force to cut down, wasn't his liver or heart. It was just wanting to be fit enough to take his bins out.
Because of the steps in his building?
Yeah, he was too unfit from drinking to manage it. That specific, personal, maybe even seemingly mundane thing was his powerful motivator.
Wow. That really hammers home the point about listening, doesn't it? Find the reason.
Absolutely. It might be something you'd never guess. But focusing on that is way more effective than any lecture about general health risks.
Okay, so that a bins anecdote. Fantastic illustration. The session then wrapped up with reflection, using the Rolfe model.
Yeah, what? So what? Now what? A classic reflective model.
So how did the professor guide them to use that, especially for their assessment?
Okay, so the what section is descriptive. What did you do? Why this activity? What did you think you knew versus what you learned?
Connecting it to the module themes, too, like global citizenship.
Right, alcohol is a global issue. Behavior change is a core concept. Describing the session itself, case studies, MI discussion. You could mention WHO stats here, perhaps.
Then the so what?
That's the analysis. What does it mean? What did you learn about MI, stages of change, communication, teamwork from the group work? How did the pre-reading help? This is where you dig into the insights. WHO stats could fit here too, showing the significance of what you learned. It's about your learning.
And the crucial bit, now what?
The most important part for practice. What will you do differently because of this? It'd have to be personal, concrete. I will try using open questions more. I will remember to ask permission before giving advice.
How will you implement it?
Exactly. And connecting that personal action back to the bigger picture. How does my improved practice contribute to addressing this global issue? Being a global citizen in your nursing role.
And acknowledging limitations, too.
Yes, being realistic. You can't save everyone. Don't beat yourself up if things don't go perfectly, especially with something as complex and socially accepted as alcohol.
The assessment tips seemed practical, too. Be concise, make those links clear, focus on the session's learning, and really spell out the personal now what.
Yeah, clear actions for the future.
So, pulling this all together from our deep dive into these notes, wow, we've seen how vital it is for nurses, for anyone really, to understand where someone is on their journey, those stages of change.
Pre-contemplation, contemplation. Knowing where they are changes everything.
And the power of these communication tools, ORRs, motivational interviewing, moving away from telling towards empowering.
It's a fundamental shift. Listening, reflecting, affirming, helping them find their own way.
And maybe the biggest insight for me is that idea that real motivation often comes from these deeply personal, sometimes unexpected places.
Like the bins.
Exactly.
Yeah.
And that finding that specific why through non-judgmental listening is just so much more powerful.
Way more powerful than generic advice or warnings.
Yeah,
And these insights, they're not just for healthcare.
that's true.
Understanding stages of change, communication that empowers, finding personal motivation that's useful in so many situations where you might want to support someone making a change.
Absolutely. So whether you're dealing with this professionally or maybe trying to understand change in your own life or someone else's, or you're just curious, hopefully this deep dive has given you some really fascinating insights and practical ideas right from the training ground. And maybe a final thought to leave you with. Given how, well, normal alcohol use is in society, how often it is used for coping, if you really stopped and listened without judgment, what kind of surprising, personal, maybe non-health related reasons for cutting back might you actually hear? And how could focusing on that specific driver, that bin's anecdote equivalent, be the key that unlocks change when everything else has failed?